Block simulation 27. Same process, fresh set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Which cells dominate ACU versus chronic inflammation? A pathologist examines two inflamed tissues. Tissue A 1-day-old abscess is dominated by one cell type. Tissue B, A, months. Long granulomatous lesion is dominated by different cells. Read the command. Cells of acute versus chronic inflammation. Acute neutrophils, chronic macrophages, lymphocytes, plasma cells. ACU inflammation is the immediate early response, minutes to days, and its hallmark cell is the neutrophil, the first leukocyte recruited to the site, producing the pus of an acute abscess. It features vascular changes, vasodilation, increased permeability, FESH early, edema, and rapid neutrophil immigration. Chronic inflammation develops over a longer time course, days to years, when the injurious stimulus persists and is dominated by mononuclear cells. Macrophages, lymphocytes, and plasma cells, along with tissue destruction and attempts at repair, angiogenesis, and fibrosis. The correct answer is D. The macrophage is the central cell of chronic inflammation, and when it organizes into epithelioid cells surrounded by lymphocytes, it forms a granuloma, A as in tuberculosis or sarcoidosis. A useful clue on labs, a left shift with neutrophilia suggests acute bacterial inflammation, while lymphocytosis or plasma cells point chronic. The neutrophil dominant acute response versus the macrophage, and lymphocyte dominant chronic response is the distinction. Which statement about esophageal motility is correct? A physiologist studies how a swallow bolus moves down the esophagus. After the bolus enters, a coordinated wave of contraction sweeps it toward the stomach, and a sphincter relaxes to let it pass. Read the command. Which statement on esophageal motility is correct? Primary peristalsis, vagal, propels bolus, LES relaxes via VIP and no. Secondary peristalsis clears residue. Swallowing has a voluntary oral phase, then an involuntary pharyngeal and esophageal phase. In the esophagus, primary peristalsis is a coordinated sequential wave of contraction orchestrated by the swallowing center and the vagus nerve that propels the bolus toward the stomach. Ahead of the bolus, the lower esophageal sphincter less relaxes, a receptive relaxation mediated by inhibitory enteric neurons releasing vasoactive intestinal peptide and nitric oxide to let the bolus enter the stomach, then recontracts to prevent reflux. Correct answer is, if a bolus is left behind, secondary peristalsis is triggered by local distension to clear it, no swallow needed. The upper third of the esophagus is skeletal muscle, vagosomatic control, and the lower 2/3 is smooth muscle. This physiology explains achalasia, where the LES fails to relax, loss of inhibitory no VIP neurons. The vaguely mediated primary peristaltic wave with NOVIP mediated LES relaxation is the correct description. Which enzymes catalyze the key irreversible gluconeogenic steps? A biochemistry student studies how the body makes new glucose during fasting, gluconeogenesis, which bypasses the 3 irreversible steps of glycolysis. Read the command. Enzymes of irreversible gluconeogenic steps. Pyruvate carboxylase, PEP carboxykinase, fructose 1,6-bisphosphatase, rate limiting glucose 6-phosphatase. Gluconeogenesis essentially reverses glycolysis, but must BYPASS the 3 irreversible glycolytic steps using 4 distinct enzymes. PYRuvate carboxylase converts pyrocholineases 6-phosphate to phoxylineogenesis. Mitochondria, it requires biotin and is activated by acetyl-CoA. PEP carboxykin, and he's activated by acetyl-CoA. PEP carboxykin converts phosphatase, converts fructose. 6-bis phosphate to fructose, 2,6-phosphate to fructose. Finally, GLUcose 6-phosphatase hydrolyzes glucose 6-phosphate to free glucose. The correct answer is B. Location matters clinically. Glucose 6-phosphatase is found mainly in the liver and kidney, which is why these organs can release free glucose into the blood, while muscle lacking it cannot. Its deficiency causes von Gierke disease, severe fasting hypoglycemia. Gluconeogenesis occurs primarily in the liver, using lactate, glycerol, and glucogenic amino acids as substrates. The 4 bypass enzymes: pyruvate carboxylase, PPK, fructose 1,6, bisphosphatase, and glucose 6-phosphatase are the answer. Which structure passes through the listed foramen correctly? An anatomist quizzes a student on which structures exit the skull through specific foramina at the cranial base. Read the command. Which structure foramen pairing is correct? Optic canal, CN2, foramen ovale V3, foramen spinosum, middle meningeal artery, jugular foramen CN9, XXI. The cranial base foramina transmits specific cranial nerves and vessels. The OPTIT canal transmits the OPTITN2 and ophthalmic artery. The superior orbital fissure transmits CN3, IV, V1, and VI. Foramen rotundum transmits CNV2 maxillary. Foramen oval transmits CNV2 mandibular. Foramen spinosum transmits the middle meningeal artery. The jugular foramen transmits CN9, X, and XI along with the internal jugular vein. The hypoglossal canal transmits CN-next tilth. Correct answer is a useful memory anchor, standing room only. Superior orbital fissure, rotundum ovale, transmit the trigeminal branches, V1, then V2, then V3 in order. Clinically, the foramen spinosum and its middle meningeal artery matter in epidural hematoma, OA fracture, there tears the artery. The optic canal for CN2, foramen ovale for V3, foramen spinosum for the middle meningeal artery, and the jugular foramen for CN9 to XI is the correct set of pairings. What is the diagnosis and the mechanism of the pain migration? A 19-year-old man has periumbilical pain that migrated over hours to the right, lower quadrant, with nausea, anorexia, low-grade fever, and tenderness at McBurney's point with rebound. The lumen of a blind-ending pouch is obstructed, often by a fecalith. Read the command, diagnosis, and why pain migrates. Periumbilical, RLQ migration, McBurney's, fecalith, acute appendicitis, visceral, T10, pain knee, parietal peritoneal irritation. This is acute appendicitis. It begins with OB obstruction of the appendiceal lumen by a fecalith in adults or L1-amphoid HY hyperplasia in children, young adults. The obstruction causes the appendix to distend, raising intraluminal pressure, compromising blood flow, and allowing bacterial overgrowth and inflammation. If untreated, it can progress to ischemia, necrosis, and perforation with peritonitis. The correct answer is E. The classic pain migration is the high-yield mechanism. Early on, the distended appendix produces visceral pain, which is poorly localized and referred to the periumbilical region. The appendix is a midgut structure, referred to the T10 dermatome. As inflammation progresses to involve the overlying parietal peritoneum, the pain becomes sharp and localized to the right lower quadrant at McBurney's point, with rebound tenderness, Rovsing, psoas, obturator signs. The visceral to parietal transition explaining periumbilical to RLQ migration is acute appendicitis. Which set of effects does cortisol produce? A physiologist studies the systemic actions of cortisol, the glucocorticoid released from the adrenal cortex under ACTH stimulation. Read the command. Which set of cortisol effects? Raises glucose, anti-inflammatory, catabolic, maintains BP permissive, inhibits bone. Cortisol's physiologic actions can be remembered as the stress hormone preparing the body for a fight. Metabolic, it raises blood glucose by stimulating gluconeogenesis and inducing insulin resistance in peripheral tissues, ensuring glucose for the brain. It is catabolic, breaking down muscle protein, proteolysis, and fat lipolysis to supply substrates. I am immune. It is anti-inflammatory and immunosuppressive. It inhibits phospholipase A2 and cytokine production, sequesters lymphocytes, and causes neutrophilia demargination. The correct answer is cardiovascular. Cortisol maintains blood pressure by upregulating alpha-1 adrenergic receptors on arterioles. It is permissive for catecholamines. Norepinephrine. Epinephrine can't work well without it, which is why adrenal insufficiency causes hypotension. It also inhibits bone formation, chronic excess osteoporosis, and inhibits fibroblast spore wound healing. Thin skin. These effects explain Cushing syndrome excess and Addison disease deficiency. The hyperglycemic, anti-inflammatory, catabolic, blood pressure maintaining profile is the correct set of cortisol actions. Which statement about NSAIDs and COX selectivity is correct? A patient with osteoarthritis takes ibuprofen for pain. A second patient takes celecoxib because he had GI bleeding on traditional NSAIDs. Read the command which NSAID COX statement is correct. Non-selective NSAIDs reversibly block COX-1-2 GI renal effects. 2 GI renal effects, celecoxib POX2 selective, less GI bleed, more CV risk. Traditional NSAIDs, ibuprofen, naproxen, indomethacin, reversibly inhibit both COX-1 and COX-2, reducing prostaglandin synthesis to produce analgesia, anti-inflammatory, and antipyretic effects. This contrasts with aspirin, which irreversibly acetylates COX. The downside is inhibition of COX-1, which makes the protective gastric prostaglandins, so non-selective NSAIDs COX-1, which makes the protective NSAIDs cause gastric ulcers and bleeding. They also reduce renal prostaglandins, afferent arteriolar vasodilators, so they can cause acute kidney injury, fluid retention, and hypertension. Correct answer is C. Lec-coxib selectively inhibits COX-2, the inducible inflammation-associated isoform, while sparing COX-1, so it preserves the protective gastric prostaglandins and causes LES, GI ulceration, and bleeding. The trade-off is cardiovascular by inhibiting endothelial COX-2-derived prostacyclin, which is antithrombotic while leaving platelet COX-1-derived thromboxane intact. COX-2 inhibitors tip the balance toward thrombosis, raising the risk of myocardial infarction and stroke. The reversible non-selective NSAID profile versus the GI-sparing but prothrombotic celecoxib is the correct statement. Which tumor marker is correctly matched to its associated malignancy? An oncologist uses serum tumor markers to monitor several patients. Read the command. Which tumor marker matches its cancer? AFP HCC germ cell, HCG chair, choriocarcinoma, CA19-9, E for pancreatic, CEA colorectal, CA125-20 ovarian, PSA prostate, calcitonin medullary thyroid. Tumor markers are mostly used to monitor treatment response and detect recurrence, not to screen. PSA is a partial exception. The high-yield matches, alpha fetoprotein IFP, is elevated in hepatocellular carcinoma and in Yolk-6E non-seminomatous germ cell tumors. Beta IACG is elevated in choriocarcinoma, hydatidiform mole, and germ cell tumors. CA19-9 is associated with pancreatic cancer. Carcinoembryonic antigen CEA is associated with colorectal and other carcinomas. The correct answer is D. Continuing, CA25 is associated with ovarian cancer, PSA, prostate-specific antigen, with prostate cancer, also benign prostatic hyperplasia, so not specific, calcitonin with medullary, thyroid carcinoma from parafollicular, C cells, and chromogranin with neuroendocrine tumors. The trap options pair markers with the wrong organ. The correct set: AFP for HCC germ cell, HCG for choriocarcinoma, CA19-9 for pancreatic, CEA for colorectal, CA225 for ovarian, PSA for prostate, calcitonin for medullary thyroid is the answer. Which organism and toxin are responsible? A 4-month-old infant develops constipation, poor feeding, a weak cry, and progressive descending FLACCID paralysis with floppiness after eating honey. An adult in another case develops diplopia, dysphagia, and descending paralysis after eating improperly honed canned food. The toxin blocks acetylcholine release. Read the command, organism, and toxin. Descending flaccid paralysis, honey, infant, canned food, adult, blocks ACH release. Clostridium botulinum, botulinum toxin. This is botulism, caused by Clostridium botulinum, a gram-positive, spore-forming, obligate anaerobe. Its botulinum toxin is a protease that cleaves snare proteins, blocking the release of acetylcholine from presynaptic terminals at the neuromuscular junction. Without acetylcholine, muscles cannot be stimulated, producing a FLACCID, Ziemding paralysis, classically starting with cranial nerves, diplopia, ptosis, dysphagia, dysarthria, the 4 Ds, and descending symmetrically, with autonomic signs and risk of respiratory failure. The correct answer is the 2 presentations are classic. Iron-fat botulism comes from ingested spores in honey or soil dust that germinate in the immature gut and produce toxin in vivo, causing the floppy baby with constipation, weak cry, and poor feeding, so honey is avoided under age 1. Adult foodborne botulism comes from preformed toxin in improperly honed canned foods. Contrast tetanus also, Clostridium, but spastic paralysis from blocking inhibitory GABA-glycine. The acetylcholine release, blocking toxin causing descending flaccid paralysis, is Clostridium botulinum. What is the condition and its treatment? A neonate given a topical anesthetic or a patient exposed to dapsone nitrites develops cyanosis unresponsive to oxygen with chocolate brown blood and a normal arterial PO2 but low measured O2 saturation. The iron and hemoglobin is in the Phe3+ ferric state. Read the command, condition, and treatment. Cyanosis unresponsive to O2. Chocolate brown blood, Phe3+. Methemoglobinemia, treat with methylene blue. This is methemoglobinemia. Normally hemoglobin iron is in the ferrous F2+ state, which binds oxygen. In methemoglobinemia, the iron is oxidized to the ferric Fe3+ state, which cannot bind oxygen. Oxidizing drugs toxins precipitate it, topical local anesthetics, benzoyl, dapsone, nitrites, nitrites, and aniline dyes. The ferric hemoglobin not only fails to carry O2, but also shifts the dissociation curve, LEF, for the remaining normal subunits, impairing O2 unloading to tissues. The correct answer is the clues are characteristic cyanosis that does not improve with supplemental oxygen, see chocolate brown, blood that doesn't turn red on exposure to air, a normal arterial PO2, the dissolved oxygen is fine, but a low measured oxygen saturation and a characteristic pulse. Oximeter reading that saturates around 85%. Treatment is methylene blue, which, via NADPH methemoglobin reductase, reduces the iron back to Phe2+, avoiding G6PD deficiency, use ascorbic acid instead. The Phe3+ hemoglobin causing oxygen unresponsive cyanosis treated with methylene blue is methemoglobinemia. What is the diagnosis, the fear complication, and the treatment? A 3-year-old child has 6 days of high fever, bilateral non-exudative conjunctivitis, cracked red lips with a strawberry tongue, a polymorphous rash, swollen erythematous hands and feet, and unilateral cervical lymphadenopathy. The feared complication involves the coronary arteries. Read the command, diagnosis, complication, treatment. Child, 5 days fever, conjunctivitis, strawberry tongue, rash, extremity changes, cervical node, Kawasaki, coronary aneurysms, IVG, plus aspirin. This is Kawasaki disease, an acute medium vessel vasculitis of young children, usually under 5, more common in those of Asian descent. The diagnosis requires fever for at least 5 days, plus the classic mucocutaneous features, remembered by crash and burn, conjunctivitis, bilateral, non-exudative, rash polymorphous, adenopathy cervical, often unilateral, strawberry tongue, cracked red lips, mucositis, hand and foot changes, erythema, edema, later desquamation, and the burn of high fever. The correct answer is E. The feared complication is the high yield point. Kawasaki disease can cause coronary artery aneurysms, which can lead to thrombosis, myocardial infarction, or sudden death, making it a leading cause of acquired heart disease in children. Treatment is iron intravenous, immunoglobulin IVIG, plus aspirin, a notable exception to avoiding aspirin in children given the cardiac risk, which reduces the aneurysm rate. Echocardiography monitors the coronaries. The medium vessel childhood vasculitis with coronary aneurysm risk treated with IVIG and aspirin is Kawasaki disease. Which structures pass through the diaphragm at the correct levels? An anatomist asks at which vertebral levels 3 major structures pass through the diaphragm. Read the command. Structures through diaphragm and levels. IVC T8, esophagus, T10, aorta, T12. The diaphragm has 3 major openings at 3 vertebral levels, and the classic mnemonic is IIVC 88101010. Eggs esophagus at 1212 actually precede aorta, the I inferior vena. Cova passes at the T8 level through the central tendon, accompanied by the right pH phrenic nerve. The esophagus passes at T10 through the muscular crura, accompanied by the vagal trunks, CNX, and the aorta passes at T12, actually posterior to the diaphragm, accompanied by the aorta processus duct and azygos vein. The correct answer is B. The accompanying structures are testable. The IVC opening T8 is in the central tendon and lets the IVC and right phrenic nerve through. The esophageal hiatus TT transmits the esophagus and the anterior and posterior vagal trunks. A hiatal hernia herniates here. The aortic hiatus T12 is the most posterior and transmits the aorta, the thoracic duct, and the azygos vein. The number pairing IVC at T8, esophagus at T10, aorta at T12 is the answer. What is a diagnosis and what defines the episode? A 24-year-old man is brought in after a week of decreased need for sleep, rapid pressure speech, grandiose plans to start 3 companies, excessive spending, increased goal-directed activity, and risky sexual behavior. He had a prior episode of major depression. The current episode impairs functioning and requires hospitalization. Read the command, diagnosis, and what defines the episode. 1 week elevated mood, I sleep need, grandiosity, pressured speech, risky behavior, impairment, bipolar I, manic episode, dig fast. This is bipolar I disorder defined by at least 1 manic episode. A manic episode is a distinct period lasting at least 1 WE-EEC, or any duration if hospitalization is required of abnormally E-elevated, expansive, or irritable mood, with increased energy goal-directed activity accompanied by at least 3 characteristic symptoms captured by the mnemonic dig fast: distractibility, indiscretion risk, taking, spending, sex, grandiosity, flight of ideas, increased in grandiosity, flight of ideas, increased activity psychomotor agitation, decreased need for sleep, and talkativeness pressured speech. The correct answer is the severity is what makes it mania bipolar rather than hypermania bipolar II. Mania lasts 1 week, causes marked impairment, may require hospitalization, and can include psychotic features. Hypermania lasts 4 days, has no marked impairment, no psychosis, and no hospitalization. A single manic episode, even without depression, suffices for bipolar I. Treatment includes mood stabilizers, lithium, valproate, and atypical antipsychotics. The 91-week manic episode with dig fast symptoms and marked impairment defines bipolar I disorder. What is the diagnosis, the enzyme, and how does it differ from albinism's amino acid cousins? A child has milky white skin, white hair, and pink light blue irises with nystagmus and reduced visual acuity, but a normal number of melanocytes. The defect is in the enzyme that converts tyrosine to melanin precursors, or in tyrosine transport. Read the command. Diagnosis, enzyme, contrast with cousins. Hypopigmentation, normal melanocyte number, tyrosinase defect, oculocutaneous albinism versus PKU, phenylalanine hydroxylase, alkaptonuria, homogentisate oxidase. This is oculocutaneous albinism. The classic form is a deficiency or absence of tyrosinase, the enzyme that converts tyrosine into dopa and then into melanin within melanocytes. The key conceptual point is that the number of melanocytes is normal. They are simply unable to produce melanin. The result is generalized hyperpigmentation of skin, hair, and eyes with nystagmus, photophobia, and reduced visual acuity from lack of retinal iris pigment, plus a markedly increased risk of sunburn and skin cancer. The correct answer is D. This sits within the tyrosine phenylalanine pathway, which is a high yield compare. Contrast. PHEK2-nuria results from deficient phenylalanine hydroxylase phenylalanine synthesis. Phenylalanine can't become tyrosine feeder, buildup, intellectual disability, musty odor. Alkaptonuria results from deficient homogentisate oxidase downstream of tyrosine. Dichronuria results from deficient phenylalanines, dichronosis. And albinism is the tyogenesis megain can't become tyrosine phenylalanine, can't become tyrosine phenylalanine, can't become tyrosine. The tyrosinase deficiency with normal melanocyte number causing hypopigmentation is oculocutaneous albinism. What is the diagnosis and the mechanism for both the lung and liver disease? A 48-year-old man with a long smoking history and COPD-like emphysema develops it at a young age, predominantly in the lower lobes, and also has abnormal liver function tests with cirrhosis. A protease inhibitor made in the liver is deficient. PAS, positive globules, are seen in hepatocytes. Read the command. Diagnosis and mechanism for lung and liver. Young Panaciner lower lobe emphysema plus liver cirrhosis. PAS positive globules. Alpha-1 antitrypsin deficiency. This is alpha-1 antitrypsin A1AT deficiency. A1AT is a protease inhibitor made in the liver whose job is to neutralize neutrophil elastase in the lungs. When A1AT is deficient or defective, elastase goes unipost and destroys the elastic tissue of the alveolar walls, producing Panaciner emphysema. Characteristically at a young age, in the lower lobes, and even in non-smokers, smoking accelerates it dramatically. This is the lung mechanism, loss of antiprotease protection. Correct answer is the liver disease has a different mechanism, and this dual pathology is the high-yield twist. In the common PZZ genotype, the abnormal A1AT protein misfolds and cannot be secreted, so it accumulates inside hepatocytes as positive diastase resistant globules, causing hepatocyte injury, cirrhosis, and increased hepatocellular carcinoma risk, so the lung suffers from too little A1AT loss of function, while the liver suffers from the retained misfolded protein toxic gain of function. The unopposed elastase emphysema plus accumulation-driven cirrhosis is alpha-1 antitrypsin deficiency. Which terms describe these, and what mediates them? A physiologist studies local blood flow regulation. In situation A, a forearm artery is occluded for 2 minutes, then released, and flow transiently surges above baseline. In situation B, an exercising muscle's flow rises in proportion to its metabolic activity. Read the command, terms and mediators. AHE, reactive hyperemia, post-occlusion surge. BHE, functional hyperemia, matches metabolism, both via local metabolites. Both phenomena are forms of local metabolic blood flow control, REAC-hyper. Hyperemia situation A is the transient INC increase in blood flow above baseline that follows a period of arterial occlusion. During the occlusion, tissue metabolites accumulate and oxygen is depleted. When flow is restored, Those vasodilatory metabolites cause a flow, surgery that repairs the oxygen debt before flow settles back to normal. A CTI functional hyperemia situation B is the increase in blood flow that matches an increase in tissue metabolic activity, as in exercising muscle, where more flow is delivered to meet higher demand. The correct answer is B. The shared mechanism is local metabolic vasodilation. When metabolism rises or oxygen falls, vasodilatory metabolites accumulate adenosine, K8 line, HPH, pH, K+, and decreased O2, relaxing arterial or smooth muscle to increase flow. This is the same principle behind autoregulation, tissues keeping flow relatively constant despite blood pressure changes, and explains the tight coupling of perfusion to metabolic need in the coronary and cerebral circulations. Reactive hyperemia after occlusion and active hyperemia with exercise, both metabolite-driven, are the answer. Which statement about colonic polyps and malignant potential is correct? A pathologist reviews colon polyps from screening colonoscopies. Read the command. Which polyp statement is correct? Hyperplastic benign. Most common. Adenomatous. D premalignant. Worse for size. Villus. High-grade dysplasia. Colonic polyps differ greatly in malignant potential. Hyperplastic polyps are the most common type, are typically small and found in the rectosigmoid and are essentially benign with no malignant potential. A key exception is large right-sided sessile serrated lesions, which don't carry risk. Adenomatous polyps are the important premalignant lesions. They follow the adenoma to carcinoma sequence APC, TRAS-IO-KRAS, and TB3. They come in tubular, tubulovulous, and villus types. The correct answer is D. The features that raise an adenoma's cancer risk are high yield, larger size, thighs mine 2 seam biome villus histology, villus bias tubulovillus, dibular I villus is villainous, and Hick grade dysplasia. Villus adenomas can also secrete mucus and cause secretory diarrhea with hypokalemia. This is why screening colonoscopy removes adenomatous polyps to interrupt the secretory diarrhea with hypokalemia. This is why screening colonoscopies to interrupt the sequence. The benign hyperplastic versus premalignant adenomatous, worse with size, villus architecture, and dysplasia distinction is the correct statement. Which statement about glucocorticoid toxicity is correct? A patient on chronic high-dose prednisone for an autoimmune disease develops central obesity, a moon face, thin skin with easy bruising, hyperglycemia, hypertension, osteoporosis, and proximal muscle weakness. He is also at risk if the drug is stopped abruptly. Read the command which glucocorticoid toxicity statement is correct. Chronic steroids, UI iatrogenic Cushing plus, HPA suppression, I must taper, adrenal crisis if abrupt stop. Chronic high-dose glucocorticoids produce iatrogenic Cushing syndrome, the same picture as endogenous cortisol excess, central obesity with a moon face and dorsocervical fat pad, thin skin with easy bruising and striae, hyperglycemia, steroid-induced diabetes, hypertension and fluid retention, hypertension, osteoporosis and avascular necrosis, proximal muscle weakness, hyperosis and avascular necrosis, proximal muscle weakness to steroid myopathy, cataracts moon, suprosin, with increased infection rise. It is the most common cause of Cushing syndrome overall. The correct answer is E. The second high yield point is HPA axis suppression. Exogenous steroids suppress hypothalamic KRH and pituitary ACTH by negative feedback, causing the adrenal glands to atrophy. If the drug is then stopped abruptly, the suppressed adrenals cannot make enough cortisol, precipitating an acute adrenal crisis hypotension shock. Therefore, chronic steroids must be tapered slowly to let the axis recover. The iatrogenic Cushing picture with HPA suppression requiring a taper is the correct statement. Which organism is responsible? And what is the migration pattern? A 6-year-old in a rural area has a cough and wheeze and an eosinophilia. Weeks later, he develops a bowel obstruction and passes a large 1530 cm roundworm in his stool. The infection began by ingesting eggs from soil. Larvae migrated through the lungs before maturing in the intestine. Read the command, organism and migration pattern. Large roundworm, soil-ingested eggs, lung migration with eosinophilia, intestinal obstruction, Ascaris lumbricoides. This is Ascaris lumbricoides, the largest intestinal roundworm nematode, reaching 1535 cm and one of the most common helminth infections worldwide. Transmission is fecal-oral. The person ingests embryonated EGGGS from soil contaminated with human feces, poor sanitation. In the small intestine, the eggs hatch into larvae, which penetrate the gut wall, into the bloodstream, and migrate to the lungs. The correct answer is B. The migration pattern is the high yield point. In the lungs, the larvae cause an eosinophilic pneumonitis, Loeffler syndrome, with cough, wheeze, and peripheral eosinophilia. The larvae are then cugged up and swallowed, returning to the intestine to mature into adult worms. A heavy worm burden can cause intestinal obstruction or biliary pancreatic blockage. Treat with albendazole or mebendazole. The egg-ingested roundworm that migrates through the lungs, Loeffler, before maturing in the gut is Ascaris lumbricoides. Which molecules are these, and what do they do? An immunology student studies how a virus-infected cell warns its neighbors and recruits defense. The infected cell secretes proteins that induce an antiviral state in nearby cells and activate natural killer cells. Read the command, which molecules and their function. Type I interferons IFN, alpha beta from infected cells. I antiviral states RNase L, PKR, upregulate MHC-I, activate NK cells. These are the TYPE. I interferons IFN alpha and IFN beta. When a cell is infected by a virus is sensing viral nucleic acid, it secretes these interferons to warn and protect any each-boring cells. They bind receptors on nearby cells and induce an antiviral state. The cells synthesize enzymes such as RNase L, which degrades viral and cellular RNA, and protein kinase R, which phosphorylates EIF2 to halt protein synthesis, so that if the virus spreads to those cells, it cannot replicate. The correct answer is E. Type I. Interferons also upregulate MHC class. I expression helping cytotoxic T cells recognize infected cells, and ACTA in-utero killer NK cells, which kill infected cells that have downregulated MHC-I. This is a key bridge of innate antiviral immunity. Contrast, IFN, gamma, a type 2 interferon from H1 cells and NK cells, which mainly activates macrophages. IFN alpha is even used therapeutically, e.g., chronic hepatitis. The IFN alpha beta type I interferons inducing the antiviral state and activating NK cells are the answer. Block 27 is done. Let's review the 5 biggest traps from this block. Trap 1. Acute inflammation is dominated by neutrophils, the first responders that form pus. Chronic inflammation is dominated by macrophages, lymphocytes, and plasma cells with granulomas and fibrosis. Don't mix the time courses. Trap 2. Methemoglobinemia is ferric Fe3 plus hemoglobin that can't carry oxygen. Cyanosis that doesn't improve with oxygen, chocolate brown blood, normal PaO2. Treat with methylene blue. Think benzocaine, dapsone, nitrites. Trap 3. Kawasaki disease in a young child. Fever 5+ days with conjunctivitis, strawberry tongue, rash, hand-foot changes, and a cervical node. Risks coronary artery aneurysms. Treat with IVG and aspirin, a rare pediatric aspirin exception. Trap 4. Alpha-1 antitrypsin deficiency hits 2 organs by 2 mechanisms. The lung gets panicenter lower lobe emphysema from unopposed elastase, too little A1AT. The liver gets cirrhosis from misfolded protein retained as PAS. Trap 5. The diaphragm openings. Inferior vena cava at T8. esophagus with the vagal trunks at T10, aorta with the thoracic duct at T12. I ate 10 eggs at 12. Don't swap the levels. 27 blocks, 540 questions. Train process, not memorization. Step logic, learn how to think, not memorize.